Now, Dr. Eamonn Shanahan is with us as always, and Eamon has brought a very special guest who will be lending us her expertise for the next half an hour. Eamon, I'll let you introduce her.
Thank you very much indeed. So I'm delighted to introduce Dr. Kate Lawler, excuse me, frog in the throat. Okay, Dr. Kate Lawler, consultant dermatologist who has just recently started in the Bons. And I understand that Kate had been working in Wales prior to this, but she'll tell you more of her story herself.
Well, Kate, you're very welcome. Lovely to meet you.
Thanks, Deirdre. Lovely to be here.
And you've started at the Bons, which is great. But tell us a little bit about your background and where you're from yourself and all that.
So I'm from Limerick, did my medical school in Limerick, did the graduate entry programme, graduated 2014 from that. I had a physics degree prior to that, so if anybody is a budding scientist and thinking about medicine, it's definitely a great career. Fell in love with dermatology very early on. That was under the guidance of Dr. Ramsay, who worked in Limerick for a long time, and I was able to meet him as a medical student. So then went on my pathway to become a dermatologist, which wasn't short, but very interesting. Had to do all the general medical specialties along the way. I did that along the west coast of Ireland. And then moved to Wales to do my dermatology training. So I was there for 6 years altogether, and worked as a consultant in my last year, but always wanted to come back home. And Tralee has always been second home. Mum and Dad are both from Tralee, so it made sense to come back here. And certainly no shortage of needs for dermatologists across Ireland, but Tralee is where we're happy to call home now.
That's wonderful. So, skin conditions generally, and Eamon was suggesting we might kick off with eczema, given the time of year and given that there's a lot of it out there. Actually, first of all, does the Irish complexion or the Irish body sort of makeup lend itself to a predisposition towards eczema, or is it the climate?
I wouldn't think so. I think actually in my experience, and certainly working in Wales, where probably 90% of the population would be Celtic skin, I would see in the clinics, particularly the paediatric clinics that I do, that I'd have a higher cohort of darker skinned individuals. So that's really interesting actually, and it always makes me think, is there something more environmentally driven about it? And potentially when people move from warmer climates and then come to this kind of climate, is their skin barrier more susceptible? So I wouldn't necessarily think it's the typical Irish skin. It's more prone to eczema. I mean, eczema is common anyway. The statistics would suggest that about 20% of children suffer from eczema, so that's 1 in 5.
That's
so
a lot.
That means that probably most people listening will have either a child themselves or know it, a family of it with a child who has eczema. Thankfully, most people with eczema, it will improve, but we never kind of guarantee that, because I've seen plenty of adults who go on to need systemic medications, and some people just don't grow out of it like they might kind of assume that would happen. So yeah, really, really common, and probably the most common thing I deal with, certainly in my paediatric clinic.
Eamon, could you, just to kind of take a step back for a second, could you outline a scenario in which you would refer one of your patients to Kate?
Yeah, so as Kate has quite rightly said, an extremely common condition, which is really the reason I wanted to talk about it today. I suppose the thing is that at this stage, it's kind of second nature. You'll see the baby coming in or the young child coming in, and you'll see the characteristic signs of the red irritated patches, particularly in the skin creases, backs of the knees, the elbows, and so on and so forth, or around the face, or you've got the child who's scrubbing themselves. There are certainly things that we can do ourselves in terms of advising parents about the simple management of eczema. I suppose the place we'd refer somebody on is the more resistant cases. So in cases in which a child's eczema is not responding to, if you like, the first line treatment, the simple straightforward treatments, and where we're struggling, and it's an aggravating condition, as any parent of a child with eczema knows, and the itch is just horrendous, and that's the reason why I don't want to see the child suffering, and I would refer the child sooner rather than later. Now, up to this point, to be very clear about this, our problem has been, as Kate has said, is the shortage of dermatologists across the whole of the country, and that's part of the reason why I'm so delighted that Kate's here now.
Yeah, and most of the time when you have eczema or your child has eczema, what a doctor will prescribe is some kind of a steroid cream.
Yeah.
Yeah, I mean, I think generally the first line management of eczema has to be moisturiser, emollient. So generally a bland emollient, that means fragrance free, very basic, that usually is bought in bulky tubs and applied liberally every day, ideally 4 times a day. I know that's really difficult. I have 3 children. I can't imagine having to put the cream on them 4 times a day. But baseline treatment for anybody with eczema, regardless of whether their skin is currently flared or not, has to be regular emollient, and that's to try and reinforce the skin barrier. So the skin barrier in people who don't have eczema keeps water in and stops allergens or irritants getting in. If the skin barrier is defective, as it is in eczema, those roles are reversed. So the skin dries out, and then irritants and allergens can get into the skin, which causes the itch, and then that leads to this itch scratch cycle. I say it to all my patients and their family, it's almost impossible to stop scratching in eczema, but it does set off this worsening itch as soon as it starts, and usually the story is that they scratch at night, they don't even realise they're doing it. But an emollient will help to reinforce the natural skin barrier without any kind of negative side effects. Yes, next line treatments, and usually only reserved for flares of eczema, would be topical steroid. GPs will often use a mild to moderate potency steroid. I suppose as a dermatologist, I'm happier going with stronger, more potent steroids, and potentially using them for a little bit longer. But I always have a conversation about, the potential side effects with them and the importance of weaning them down in order to prevent flare-ups, which often people will experience if they stop their topical steroids suddenly. And then in terms of further management, I mean, there's lots of other things that we have available these days, which makes the treatment of the more severe cases a little bit, there's a little bit more options there. Other topical treatments would include calcineurin inhibitors. So some patients have used them. They're probably less well known in the general public, but they are still anti-inflammatory, still need to be prescribed, but don't tend to have those side effects of thinning the skin if they're used for many, many years. They can lead to a little bit of stinging initially and some photosensitivity, but they're my kind of go-to if the skin is flaring regularly, particularly on the face, and patients or their parents are reluctant to use topical steroid.
So let me present you with a scenario. A patient comes into you, they have very bad eczema, they're doing all the itching. You prescribe a stronger steroid than they might get from their own GP or across the counter in the pharmacist or whatever. So that clears up the eczema, but it comes back. Is there anything at all you can do to get it to stop coming back?
It goes back to the key that Kate's been saying. It's hard work. It genuinely is hard work. It's the application of moisturiser, the emollient 4 times a day, and that's the bit that I think, unfortunately, there aren't any shortcuts to this, and that's what's really hard about being the parent of a child with eczema. Is that the steroid is, if you like, the fallback position. It's the first thing is the emollient, and applying that, the emollient, and applying that frequently. And it also includes things like how to bathe the child and so on. There's lots of details, and that's why Kate and her colleagues, the dermatology nurses, are so useful to us, because they can give the parents the specific detailed advice about moisturising the skin.
And I presume that nowadays, especially we'll say teenage girls, they love their hair care products and their shower gels and their body scrubs and all this kind of thing. But there's no point, I presume, in them using these emollients if they're going to hop into the shower and put all this stuff on their hair and it's all coming down all over their body. It's counterproductive, I'd imagine.
It is, because I suppose most of those things are irritant to eczema-prone skin, and I feel really mean saying to parents, you cannot give bubble baths. You know, you have to avoid the fragranced products. And yes, in that age group, and teenage boys love things like Lynx and stuff. So yes, it can be difficult, but those kind of products just drive eczema. And the other important thing about eczema is that we don't have a cure. So it's a chronic condition. So no matter what treatment patients are on, and at this point in time, we have some patients that are on even injectable forms of treatment for eczema. They still need to use their regular emollient, and they'll still need to use topical steroid or calcineurin inhibitors from time to time. But ultimately, even if their skin goes from, 90% covered to completely clear with the injections, which can happen, they will still be prone to eczema if they stop that treatment. So there's no cure.
That's the thing. Okay, well, we're going to take a break. We've a lot of questions for you about, not just about eczema, Kate, but about lots of other skin conditions as well, if you're happy to field those. But we will take a break first of all and remind listeners 066 712 3666 to give us a call. Welcome back. Dr. Kate Lawler, consultant dermatologist at the Bons Secours Hospital in Tralee, is with us, as is Dr. Eamonn Shanahan, who's with us every week. We're talking about skin conditions, and lots of you are getting in touch. We'll start with this one, Kate. Listener is in her mid-40s. She recently developed bad scalp psoriasis. This is going on for about 7 years following chemotherapy. She says, I've tried many different shampoos, lotions, supplements, steroids, etc. Nothing seems to calm it down. Steroids did work short term, but then it came back again as bad as ever. Any suggestions?
So I suppose akin to eczema, psoriasis is a chronic condition. Again, meaning that if the treatments work and you stop them, it is going to recur. Scalp psoriasis in particular is very resistant to treatment, and I have treated patients with systemic treatment, so either tablets or injection forms of treatment when they suffer on their scalp alone. It would be something that we would consider a high impact site. So even though it's not, widespread, it can cause a lot of distress to people. So, I mean, topical steroids, yes, you don't want to be using them forever, and you do want to give them a break from time to time. But if it's worked, I would suggest using them. You can get some topical treatments that you leave on for up to 8 hours if you can tolerate it. And then it's combed off with a fine tooth comb to lift the scale, and then washed out with a coal tar based shampoo. But yes, it can be very resistant to treatment, and I have used stronger treatments on scalp psoriasis.
Okay, so maybe a call to your office might be,
potentially,
to your rooms might be an idea for that person. Now, this next one, you're both going to have to help me with pronunciations. It's a lady in her 60s who has a skin condition. Lichen
planus, yeah.
Or is it Lichen planopilaris? Or Lichen planus?
Lichen planus. Is that how you say it?
Yeah.
She's had it for several years in the back of her left leg. It flares up badly occasionally, and she's wondering, is this pattern likely to continue?
Again, lichen planus, very itchy condition. I just wonder, was it biopsied, or how the diagnosis was made? That's the first thing in any condition to make the correct diagnosis. It'll sound like I'm repeating myself now, but topical steroid does usually work. I've rarely had to give anything stronger than topical steroid, but once in a while, if it's very disseminated, stronger treatments can work. But yes, it is a relatively chronic condition.
Yeah, I think the general advice is there's many, but not all, the skin conditions that will respond to steroids, to steroid ointment. So what you're looking for is the lowest strength for the shortest period of time. Now, the lowest strength might be a very strong strength, but then for the shortest period of time. And I think one of the things we would be both concerned about is the inappropriate use of steroids. We're particularly concerned about the application of steroids to those parts of the body where the skin is thin. So particularly around the face and around the genitalia, we're trying to avoid that if possible. And again, try to use the steroids for the shortest part. So you use whatever strength is appropriate to bring the condition under control, and then back off on the strength reasonably quickly.
Next question is from a 50-year-old female. She has itchy, dry patches on the back of her hand and under her foot. She's been using Dactarin, but can't seem to get rid of it. Could you recommend anything else I could try, she asks?
It sounds like she's treating fungal. I suppose may not be fungal. Usually if you want to diagnose a fungal skin infection, skin scrapings are helpful. But if the treatment is not working, it might not be the right diagnosis. So it's, I suppose, again, it's coming back to making the diagnosis in the first place. Itchy patches could be just eczema rather than a fungal skin infection.
Okay, and I think this next one is perhaps along the same lines from Kathleen in West Kerry. She has noticed pink blotches on the back of her hand. First on one hand, then it turned up on the other hand. Got quite sore. Another one came on my face. I'm applying Betnavate and I have a citrine allergy. After that's an antihistamine. An antihistamine. After doctor's advice, it was only a little itchy at first. I would appreciate if you could enlighten me of the cause.
Given the sites, I would wonder, is it sun damage? So actinic keratosis is sun damage, can be quite common on the backs of the hands and even more so on the face. Again, difficult to recommend if you don't know the diagnosis, but if Betnavate is not helping, then it may need some different topical treatment.
I think part of the thing there is going to be trying to work out the diagnosis. There are a couple of things we were talking earlier on about the Celtic skin, and one of the things the Celtic skin is prone to, as we've said many times over the years, unfortunately, is skin cancer. And the actinic keratoses are not precancerous, but they're kind of along the direction. I think one of the things that, again, having access to an enhanced dermatology service is actually biopsying these lesions, and a biopsy just literally takes a small bit of tissue for analysis. But because you can then apply the most appropriate treatment, the one thing I would be concerned about is betamethasone ointment, which is what the Betnavate is. That's one of the ones we try to avoid using in the face if possible. If possible, there might be times you might need to use, but I would be really careful about using it in the first place.
Yeah, I'd be reluctant to use Betnavate on the face as well.
Sarah's in Tralee. She got bitten by an insect and had a huge reaction to it. She says, I'm now covered in 1 million spots all over my body. I did get a cream and a repeat prescription. 1 month on, I'm still covered in these spots. Surely it can't still be a reaction to the bite.
Yeah, I mean, you can sometimes get, we call it an id reaction, a secondary reaction, if you get something that's causes enough, I suppose, response in your immune system, and then you can develop secondary rashes to it. But I mean, if it's that widespread, she probably needs to see her GP in the first instance to see if there's another explanation or if she needs alternative treatment.
The one thing she didn't say, and I think it would have some bearing, is whether these lesions are itchy or not.
Okay, yeah, no, she didn't actually say.
No, but that would be one of the questions we'd ask.
Now, 48-year-old male next. He has developed a very aggressive itch/irritation on his scalp and face over the last 2 months. It doesn't show as a rash. He says, I've tried different types of moisturisers, shampoos, conditioners, etc. No improvement. I recently applied Nizoral Scalp Tonic, which calmed it significantly. He said, I had a few glasses of beer over the weekend over dinner and it flared up again a day later. My GP reckons it may not be a skin-related problem. Any thoughts? He seems to be trying to make a connection between the beer and...
Yeah, I mean, itch on... Well, he said it's not rashy, but I suppose it sounds a little bit like seborrheic dermatitis. So that's a common condition on the scalp, which can cause some itch, but it's usually a bit flaky. Yeah. I mean, rashes that flare with alcohol, I would think of rosacea, but again, it doesn't sound like it's very rashy.
Yeah, that's typically cross face. I mean, it's interesting that he used ketoconazole shampoo. Ketoconazole is a fairly important antifungal, and the interesting thing is the fact that it did seem to calm down with the ketoconazole. It only works against fungal activity. Now, the single most common cause of fungal rash on the scalp is dandruff, and bad dandruff is bad fungal infection of the scalp, and that's what the ketoconazole shampoo is for. So it does sound as if there's a fungal element to this, and occasionally you can get these fungal rashes in the head who actually go down onto the face. You can get bits of fungus growing along the eyelids and around the noses and places like that. So using the ketoconazole as not just as a shampoo but as a facial wash can sometimes be helpful. Best thing to do is go back and chat to their own GP again about that.
Now, this next listener, Kate, has eczema I don't know whether it's a man or a woman, has eczema inside their ear for a long time. Can you recommend treatment? That sounds painful.
It is. It's hard, and it kind of is a little bit beyond what I do, because if it's within the ear, then I'm not really experienced in treating that. But yes, because of the dryness and that flake, and then if those flakes go into the ear, so I think sometimes it's getting those suctioned. Eamon, you might have
that's
a bit
right.
more experience.
Yeah. So the issue there is that you get these what they call squames, or bits of skin coming off on the inside, and they then kind of macerate inside in the ear. You can get this horrible, sticky, yucky, smelly thing inside, and then it's desperately itching. You're trying to scratch it, and of course the old cliche, but don't put anything in your ear bigger than your elbow. People are putting matchsticks and things inside their ear, but the problem is all they're doing then is they're irritating the inside of the ear, making the situation worse. Emollients again, but in this case simple as warm olive oil just to soften the stuff that's inside there, getting microsuction to suction out what's there, and then somebody has a good look inside to see what the story is. Again, we've seen this over and over again, the use of topical steroids or steroid drops you can use. One of the things I think that I would always kind of at the back of my head though is that if this is a persistent problem, not to assume it's eczema, just to make sure that there's nothing else going on. There's a condition there called cholesteatoma, in which case you'd need to see an ear, nose and throat specialist.
Okay, we've only time for, I'd say, one more possibly. Caller's son has recurring impetigo. Is that how you say it?
Impetigo.
Impetigo. I'm getting all this wrong. Around the nose and the mouth. He's had it for years and it reoccurs frequently. Treatment can be an antibiotic, or they find pseudocreme helpful. Would the doctor recommend anything to stop it reoccurring?
So, first of all, impetigo is a bacterial infection caused by Staphylococcus aureus. Now, they're big words, but staph is very common on all our skin. But if he has a background of eczema and the skin barrier is defective, then that will again increase the likelihood of getting it. If he doesn't have eczema, you can still get it, and it's more common in children. Staph can live in the nose, so usually if I see somebody with recurrent staph, so impetigo, I swab the nose, and if it shows staph, then I treat it with mupirocin ointment. Needs a prescription 3 times a day, 5 days, and sometimes an antibacterial wash as well in the shower for about a week. That's usually how I treat it, so it might be worth going to the GP about that.
Okay, and I'm going to squeeze one more in, Kate, because we mightn't have you again for another 12 months. Female in her 70s has suffered cellulitis 3 times over the last year on the shin area just above her ankle. It has a very raw appearance. The surface of the skin looks to be damaged. The skin is very dry and the appearance is raw red. What can she apply to improve the appearance of the skin and bring down the colour and restore the skin surface? She doesn't want to be left with a mark permanently.
So often if I see recurrent cellulitis, I have a look between the toes, because sometimes there can be chronic athlete's foot, so tinea pedis, and that can be the portal of infection then for the bacterial bug to get in and cause the cellulitis. So that's one thing. First of all, check if you have athlete's foot and treat that if you do. In terms of protecting the skin, it again boils down to the bland emollient. Sometimes on the legs I'll go for something a bit greasy, like like a Vaseline based ointment, just rubbing it downwards in the direction of hair growth so that you don't get irritation of the hair follicles. Legs are slower to heal than any other part. I suppose the blood supply to the legs isn't as good as the upper body, and often people can be left with this post-inflammatory hyperpigmentation, which can take a few months to fade, but again just reinforcing that skin barrier. But it sounds like she probably needs to look or have it looked into why she's getting recurrent cellulitis in the first place.
Very good. Unfortunately, we're going to have to leave it there. It goes by very quickly, and the questions, we've got loads and loads of questions for you. So, Eamon, you might have a look over some of these next week, perhaps. Right, Kate, it's been great having you, and wonderful to have someone of your expertise on the show with us. So you might come back again, will you?
I'd love to come back. Thank you. It's been wonderful.
A pleasure. Thank you so much, consultant dermatologist Dr. Kate Lawler. Thank you as always to Eamon, who'll be back next week. We'll take a break.